Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Laboratory Corporation of America.
Hello, everybody. Welcome to this activity entitled Missed and at Risk, Rewriting the Cervical Cancer Screening Story. I'm your moderator, Anita Nelson, Professor of Obstetrics and Gynecology at the Western University of Health Sciences. And joining me today on faculty are two amazing people, Dr. Warner K. He, who is Professor and Chair in the Department of Obstetrics and Gynecology at the University of Alabama, Birmingham, and Ritu Salani, who is professor in the Division of Gynecologic Oncology at the David Geffen School of Medicine at UCLA. Today, in this program, we're going to discuss the following: the current landscape of cervical cancer screening. We're going to discuss overcoming obstacles to screening. And we're going to talk about how to manage screenings, strategies to encourage screening adherence. Now I'm going to turn it over to Ritu to discuss the current landscape of cervical cancer screening.
Thank you so much for this introduction, and I'm really excited to talk about this very important topic. So it's important to first just recognize the cervical cancer statistics. In the United States, this year, it's estimated that we're going to have about 13,000 cases affecting women with cervical cancer and an estimated 4,320 deaths. It's important to recognize that 90% plus of cervical cancers are caused by HPV infections. It is most commonly diagnosed in young women ages 35 to 45, with the average age of diagnosis being around 50. It's also important to note that about 20% of all cervical cancers are diagnosed in women over the age of 65. Some recognized risk factors include HIV, and women with HIV are 6 times more likely to develop cervical cancers than HIV negative women. I already mentioned that one of the most important risk factors for cervical cancer is HPV, and this is typically associated with the high risk or oncogenic types of HPV, which most commonly are HPV 16 and 18, and these account for over 70% of cervical cancers worldwide. We also know other risk factors can potentiate the acquisition of HPV, and this can include sexual activity at an early age or before age 18, multiple sexual partners, a weakened immune system, which is examples include HIV infections or AIDS diagnosis, transplant patients. We know smoking history and use of oral contraceptives may also be a risk factor. And we also know that low socioeconomic status and access to care can be huge barriers. Women who were exposed to DES in utero may also be at risk for cervical cancer, and this is typically HPV independent. When we think about cervical cancer detection, screening can play a really important part. There are two main guidelines that exist within the United States that we use for cervical cancer screening, and I want to quickly highlight some of the key facts. Here you can see the United States Prevention Services Task Force recommendations. There are a couple differences between these two guidelines, so I want to kind of highlight those. The US PSTF guidelines recommend screening starting at age 21, and this is typically with cytology alone, and that can be done for every 3 years. Starting at age 30, the recommendation is for HPV testing or HPV and cytology testing, and this can be done every 5 years. I want to highlight that screening is reserved for patients who are otherwise asymptomatic. They don't have precancerous changes on their cervix, and they don't have any symptoms. If they do, there are different recommendations for those patients. So these are for kind of normal situations. One of the key recommendations is that there should screening after age 65 does not need to continue if a patient has had normal screening previously or at least within the last 10 years. And this is because the risk of developing cervical cancer after that age goes down. But this is really important to recognize that these patients must have had normal screening beforehand. After hysterectomy, screening is no longer necessary as long as the patient didn't have a history of cervical dysplasia. The American Cancer Society also has guidelines, which are actually very similar. There's one key difference, and that's that screening starts at age 25, and this can be done with HPV as a primary test measure. Cytology can also be done, but these are just the main difference between these two. We're going to talk a little bit more about vaccination, but it's important to know that patients who are vaccinated still require appropriate screening guidelines as they are not exempt from screening. I think the most important thing is that screening can really prevent precancerous lesions and cervical cancer. But unfortunately, we've seen decreased rates of cervical cancer screening. Here you can see a graph depicting the percentage of females who were aged 21 to 65, that appropriate screening time frame, of patients who were up to date with cervical cancer screening. And although we have good rates of screening, it's reported that 75 percent of women between those ages have up to date cervical cancer screening. It's not clearly enough. And we still see rates of cervical cancer developing and cervical dysplasia, which requires additional intervention. I want to highlight some key barriers to cervical cancer screening in the United States. First, underrepresented minorities or racial disparities are one of the biggest factors. This may impact a patient's ability to have screening, but also their perceptions about it. So, education can be a key factor in helping patients receive the appropriate screening. Patients who are rural or live in areas where there may not be readily accessible care, especially preventative care, may also experience delays or miss important screening metrics. There are also important factors such as sexual and gender minorities. As we're understanding more about cervical cancer screening and barriers, it's important to recognize that all patients who have a cervix should undergo cervical cancer screening. Additional factors, including religious beliefs or limited English proficiency, can also impact access to care. One of the most important things, though, is healthcare systems and financial and logistical barriers. This can include access to care, ability to have insurance coverage, or financial burdens of care. And overcoming these burdens can be really important because the screening costs are going to be significantly less than any treatment cost. So, understanding how to overcome these barriers and helping patients and their families overcome these barriers is going to be really important. I'm now going to pass it over to my friend and colleague, Dr. He, to discuss obstacles to cancer screening.
So thrilled to be on this with Dr. Nelson and Dr. Solani, and I'm going to talk a little bit more about the specifics related to screening. So I kind of want to start with just the basic tenets and why we do cervical cancer screening and what we look at, what we look for. I think there's this held belief that when we do screening, we're looking for cancer. We're actually not looking for cancer per se. We're actually looking for what we call pre-invasive disease of the cervix, often known as CIN, dysplasia. There's lots of different types of terminology, but we're trying to basically diagnose what we know is legitimate precursors for the development of cervical cancer because it's much easier and a lot less invasive for us to treat it at that stage. So again, we break the cycle of developing cancer by diagnosing pre-malignant lesions, treating them, and hopefully getting to a state of normalcy when it comes to their subsequent screening. So that's ultimately the goal. So, how do we screen currently in the United States? So, there are various different methods. I think the longest method and the one that's best known to many people in the United States is just using a pap smear, or also known as cytology. In this country, we have largely transitioned to what's known as liquid based cytology, which is doing the pap, putting it into a vial, and that vial is then processed in the cytology lab, and you get the result. The other option is to use what's known as primary HPV screening or using high risk HPV testing by itself. And there's been a lot of literature published in this area, and that can be done two ways. We can do it as a clinician collected sample, we can do it as a self collection, which I'll get into a second. And what we're really advocating for is the use of FDA validated and cleared assays, mainly because they've been clinically validated to be used in the screening setting. Co-testing, which is the combination of both cytology and HPV, which is well known to this country and has been widely adopted since basically 2010. And those tests are run together, and then basically we decide what happens after that. And in most circumstances, you're going to get a normal PAP and a negative HPV test. As mentioned earlier, that there has that self collection with a vaginal swab by the patient in a healthcare setting has been approved using HPV as the test. And as of this year, literally, that there is a platform that allows people to do self collection using HPV testing at home. A prescription is required, but what we're hoping is in the near future that we'll be able to do this kind of self collection at home with the vast majority of patients, so they don't necessarily have to come into a provider to get tested. So these are all the current methodologies. In terms of the tests themselves, we basically there are what we describe as conventional HPV nucleic acid tests. There are several FDA approved assays that are out there presently. Many of these assays actually also do what's known as genotyping. So basically, you not only assess whether that a patient has one of the 14 high risk types, but may look for types like 16 and 18 specifically, which confer higher risk developing both precancerous changes as well as cancer. There's also what we call near point of care testing as well, which has been a huge area of interest both in the United States and internationally. And again, going back, these tests can be done either by a clinician or provider, where they basically swab the cervix, and also could be also be driven by the patient herself, where they can actually place a vaginal sample and actually collect that either in a physician or provider's office, or now at home. And so these are just the general paradigm of how we do this type of testing. So let's talk a little bit about HPV testing for cervical cancer. And as mentioned earlier, the long standard has been basically PAP or cytology testing. We're highly familiar with that. We've been doing it for basically 40 or 50 years. But in this country, we have transitioned to HPV testing mainly because we know that it's a better test, it's more sensitive, and that we also know that if you rely on cytology alone, that providers are invariably going to miss disease along the way. So there's been a huge amount of attention and focus pace on HPV testing, either in combination with cytology or by itself as a primary test. So, what are the advantages? Well, the advantages are that you can do a self sample collection, which is a huge win, as I'll talk about in a second. There's quality control, highly sensitive, much more sensitive again than cytology by itself. But importantly, it allows us to provide a longer rescreening interval. And there's great confidence in that when we know that a woman is HPV negative, their risk of developing pre-invasive invasive disease is much lower than, let's say, someone who's getting tested with the pap smear or cytology. So what are the cons? It's a laboratory test. It can be expensive. Doesn't perform all that well in younger women, specifically under 25 years of age. The results are not provided in real time, but also realize cytology results are not provided in real time as well. So you got usually have to wait several days to get those results, and that these tests limit the ability to screen and treat in the same doctor's visit. So hopefully in the future that will be less of a concern, but in 2025, that's the reality that we face today. So in terms of the results, basically negative is basically really defined as anything less than 1.0 picograms per milliliter. We do what's known as a receiver operator curve, which is basically a benchmark between sensitivity and specificity. And so, is it possible for a patient with a negative test to really have HPV? Yes, but the clinical significance of that is pretty low. And so, this has been a pretty well validated benchmark in terms of defining what's positive versus negative. So let's talk a little bit about cytology and pass-through testing again. We basically swab the entire squamous columnar junction. And when I started my training, we did this on literally a singular or two glass slides that was then fixed. Now in 2025 in the United States, I would say at least 99% of cytology is liquid based, and there are two main platforms that are done to do this. I think the exciting thing is that we now do what's known as image based or image guided screening. So a lot of these liquid based cytology tests are sent through essentially an AI driven image analyzer, and they highlight the ones they think are very abnormal to be manually read. But the problem with cytology is that it's really hard to take this well-known, well-validated, highly successful screening platform and put it in a low resource setting. Why? Because it requires highly skilled personnel, training, quality control, and to do that year by year becomes highly expensive and hard to replicate. And thus going to why we're so interested in things like HPV testing. As I mentioned earlier, what's the disadvantage with cytology currently in the present day is that it has a very low sensitivity. The low sensitivity is about 50%, or in other words, the equivalent of a coin toss. And you have to do repeated testing to get that sensitivity up to the 80 to 90% range. But this is the concern that we have with cytology is by itself, it's probably not probably, it's definitely it's the least effective screening test given all the other tests that are available presently in the United States. So, in terms of the interpretation of results, obviously you get this result that's called a NILM, NILM, which stands for a negative for intraepithelial lesion or malignancy. That essentially implies that there are no significant abnormalities seen on that test, and then we usually recommend that that test be repeated every 3 to 5 years. Generally, it's every 3 years if you're doing cytology by itself. If it's abnormal, the extent or the degree of the abnormality is classified used by something called the Bethesda system that has been revised at least twice already. And in the United States, we rely on the Bethesda system extensively to categorize an abnormal pap smear. So, very briefly, I want to talk a little bit about self collection. What is this? So, well, self collection, and some people use the term self sampling. They're basically the same thing. Is where a swab is placed in the vagina. You do your collection there, and then you put it into a vial, and then basically high risk HPV testing is done off that collection, right? So, who benefits from this? Well, obviously, the people that benefit from this are individuals who can't get access to a provider. Let's say they live in a remote rural area, they have challenges getting to come to see the provider. The benefit is that they can do this potentially at home. The other benefit is not everyone wants to undergo the uncomfortable pelvic exam to get a PAP, and this actually allows the patient to control the collection on their own terms in a sort of more comfortable setting. So it's a win. It's a huge win. So the collection and the processing is pretty much exactly the same as if you did a clinician collected sample of the cervix. It's an HPV test. It goes to the lab. You get a result, hopefully in about a week, and then basically you go forward from there. And so there's a huge win with self collection, and I think you're going to hear a lot more of this in the upcoming years as a legitimate, basically alternative to provider collection. So the American Cancer Society has put out some excellent guidance, and you can get it off their website from the cervical roundtable.org resource center about self collection. Again, this is all HPV testing driven. There is a present FDA option that allows a patient to do this at home. It requires a prescription, and this is also an acceptable alternative for individuals who don't want to undergo a pap smear in the doctor's office and want to undergo a pelvic exam. And the data demonstrates that the efficacy or the sensitivity of this is very similar between clinician collected and patient collected and self sampling. The challenge is obviously is that if you have an abnormal test, you still got to come in. But again, we're presuming that the majority of people who are screened are going to be screened negative, and it provides a lot of reassurance to not just the patient, but the provider that their risk is relatively low. Again, follow up is hugely important here. There are some individuals who are never going to be eligible for self collection, including women who are HIV positive, individuals that have cervical cancer. And there's some really important clinical and operational considerations that have to be thought of when instituting a self collection paradigm or program. So, in other words, how are you going to get patients in if they have an abnormal result? How is the colposcopy going to be done? How are they going to be notified? I think these are things that we operationally have to pay more close attention to. And so, with that, I'm going to pass this on to my colleague, Dr. Nelson, who's going to talk about how to have meaningful conversations to maximize screening. So, I'll hand it over to you, Dr. Nelson.
Thank you, Dr. Ha. That was very comprehensive. I appreciate that. But this part of the talk is just going to be reinforcing some of the message that you got. What is the role of the primary care provider in facilitating screening and making sure that it gets done on a timely basis? And this comes from a cadre of resources, but has definitely been linked to the CDC, where they've done some studies to show it is so important to make clear, strong recommendation and to use shared decision making. Very important with the patient. We want to be very proactive in our outreach using registries and reminders, and don't just rely on opportunistic screening. She's here, right? That we want to make sure that this is done in a very organized way. And as we just heard, this wonderful option to do the self collection of the HPV testing, especially via the direct mail or the opt out kits. I think this model can be really well understood. Yes, we need a prescription for this, but it's the same way we do with fecal occult blood screening for colon cancer. So that it's very comfortable for women to be able to screen themselves at home. It's just a slightly different approach. We want to certainly pair this with navigation and close that loop on follow up that we heard about. And we want to definitely reduce the structural barriers that we've learned from the literature already. If we can, how about offering clinic based self collection options? She's here today, just as we do with STIs. If she doesn't want to have a full pelvic exam, maybe she could give us a urine sample, or as we're doing the swab in the vagina also, and we can do the tracking. We want to target people with the largest gaps, and we heard about several of them in the last two talks, people in rural areas, minority areas, in the safety net areas. And we want to promote that guideline concordant intervals and actively prevent overuse. I think that's something that people haven't thought about very much, but women are still oftentimes much more comfortable with annual screening, and that's really not necessary, and it can lead to problems. And we want to do certainly implement practice substitution and structural change management. But if you just take a look at the big view here, screening and vaccination are the two tools that we have available today to effectively eliminate cervical cancer. But it takes a coordinated effort of all the elements in the healthcare team really to maximize the effectiveness of this screening. Just as with every clinical encounter, the healthcare system today, they remind patients that they need a vaccination or a mammogram or other important service. The patient who's late for her cervical cancer screening really needs to be reminded. If possible, can the collection be done at that very moment? And since it's self-collected, gosh, could we just give her the kit and she could step in behind the curtain or maybe to the ladies' room and do it? So this is now possible because of this self collection without disturbing the flow of the clinic at all. But as we've heard from two different sources already, and I think you've already been thinking about this, the real challenge is to reach those who are due or more likely overdue for testing, because most cervical cancer in this country arises in people who've never been tested, never been screened, or certainly haven't kept up with the latest recommendations for screening. They are the most high risk, and we see this not only in this country, but also around the world. Direct mailing of the self collection kits has been shown to result in a higher screening completion. But what's a little discouraging, and that may be because it's so new, that the numbers were still very low, that we had 14.9% of people respond when we sent it. It was 5% when they were required to come into the office. We certainly can do better. And 15% is better than 5%. So we're happy to take the win whenever we can. But I'm hoping to see those numbers increase as this becomes more mainstream. So we may need to make it more mainstream by developing creative programs, particularly if follow-up care is needed. You heard Dr. Haas say that this is going to be a real challenge. If we get the screening done, how are we going to link to the care that we need for the abnormals? Maybe we can develop public health programs. We have people who are going out into the streets offering people care among the unhoused, and self-collection kits there could be very helpful. Can we reach into the correctional facilities and offer self collection kits? But for us in the normal daily use, for the patient in the office who needs a screening, Her options can be really phrased as good news. She has a choice. If she needs a pelvic exam for some other reason, maybe the traditional cervical specimen can be obtained by the clinician with little added time or discomfort, or not. She still has the option to choose to do it herself. We do know we have this few little studies that suggest that the clinician obtained specimen might be slightly more sensitive than the patient. But again, something is better than nothing. If she doesn't need a pelvic exam and does not need to be screened, uh, but does need to be screened, then she can simply swab her vagina and be confident that she can get the specimen that can be used to determine if she has the high risk virus or not. So, when we're looking at what we want to do to emphasize uh, the compliance with current guidelines. We've got the strategies for the patients and the strategies for the clinicians. Constant reminders. I don't want to be a nag here, but don't let her think that if she needs it and we don't say anything, maybe she doesn't need it. We really want to be very concrete and make sure everyone on the team is aware of the latest guidelines and the recommendations. This has been a real challenge in cervical cancer screening over the years because as we learned the natural history of HPV, we kept changing what the guidelines were, and we want to make sure everybody on the team is singing the same story. And for the clinician, certainly in the master problem list include the need, have a blank on the EMR that needs to be completed. Is she up to date? Maybe we all need to obtain webinars to keep updated, but none of us can keep that level of detail about what to do for follow up. And it gives us all those screening options that we heard from Dr. Ha, and to make sure that we give complete care. So again, the big challenge I think in the next step is if we get the HPV viral test results, how do we handle the abnormal results? And we have to recognize that the ordering clinician does have a responsibility to motivate the patient to the next level of evaluation and then on to treatment. If you've taken the patient on and you get an abnormal value, it's going to be like any other abnormal. And it may be more challenging to get the patient to come to this next step because she was the one who didn't want to come in the first place. But perhaps by emphasizing the reality of having an abnormal finding, maybe that can make it easier to persuade her to come in for her follow up. But we also need to make sure that she's linked to local resources in where if she has challenges, financial challenges, she can get lower cost services if they're available. So again, the counseling message that we want to say, this is a screening test. It is not a final diagnosis. I think when people come for a pap smear, they think they're getting tested, as we heard, do I have cervical cancer? And we got to send those messages. This is a screening test. It's not going to give you an answer one way or the other. This is step one. We need to do further testing if this comes out positive. But if it comes out negative, you've got a chance to that you take a deep breath and we'll check again in the future. We have new tools. They may help us. Having more options may help us reach those ladies who definitely need it. But it takes a partnership between the patient and the clinician working together to eliminate this terrible disease. So, Dr. Solani, do you have any closing remarks, takeaway messages?
Yeah, what a great overview. And I think that the most important thing is that screening really can make an impact. One important thing to highlight is that, screening really is critical. It's important to note that even though the incidence of cervical cancer is decreasing, the rate of deaths from cervical cancer is actually is staying steady. And one of the reasons is we're not diagnosing patients in early stages or in those precancerous stages. So the impact of screening can never be overstated. And now that we have a new avenue to test this, which may be more comfortable for patients or make it more accessible, I think both of those rates should really start to decline.
Dr. Ha?
Yeah, I mean, thanks for the opportunity to say a couple words. I think one for the listeners and viewers, cervical cancer again is a largely preventable cancer. And the one thing that we really haven't talked in great depth on this is the impact of vaccination, right? Yeah, I think undoubtedly vaccination in this country worldwide is going to have an enormous effect. However, that doesn't mean screening goes away. And I can't help but think that the majority of my patients who I see in my clinic with newly diagnosed cervical cancer, almost every single one of them could have been prevented at some point, right? And whether it's access to screening or whether they were managed appropriately because of the abnormal screening tests or whether they had access to treatment, almost every single one of these patients is preventable. And I think the advent of self collection allows the ability to empower not just the provider, but the patient to do the screening in a way that is more acceptable to them. And it's chipping away at those multitude of barriers, like you talked, Dr. Nelson, about why people don't get screened, why providers have access to it. So I hope it's a kind of a new age in terms of reinvigorating the importance of screening and how it's still very relevant in this day.
Thank you so very much. Well, in this session, we've reviewed how to identify those who need testing and to remind ourselves to mark that need on her chart. Remind people at each and every opportunity that of the need if there is screening and streamline her access to care. We've also come to appreciate, as we said, that testing is only the first step. We need to creatively brainstorm ways to use this new technology to comprehensively reach those who are most likely to get cervical cancer, and in order to make a significant reduction in this terrible disease. Well, I want to thank you very much, both of you, my colleagues, for joining us in this important discussion. And I want to thank the audience for their participation. Invite them to go on and answer the evaluation questions. Thank you.